Welcome, everyone, to another episode of Practice Perspectives. Today, we're going to do interview number 2 of Brett Kessler. Brett is the president-elect of the ADA, elevated to that position in October of 2023. And he's a fellow of the College of Dentists going back to 2007. He's owned a full fee-for-service comprehensive care practice. He's been in several other practice models, so he has a tremendous amount of experience in a lot of areas of dentistry, tremendous perspective. He's a 1995 graduate of the University of Illinois School of Dentistry. So welcome back, Brett.
Thanks, Paul. Great to be here.
The last interview we did with Brett was focused really on Brett's story and how he got up to this amazing spot of influence and leadership. Today we're going to focus on really the future of dentists, which is what's Brett's task to do, is to help lead us into the future. And one of the reasons that I wanted to do this was roughly about a month ago, the ADA just published its most recent data on the trends in dentistry. I basically pulled this off the ADA's podcast, and the ADA's chief economist, Marco, was kind of giving us a review of that. So basically he said, what are the 3 main challenges that people surveyed answered were their biggest challenges that they foresaw in this year, 2024. And number 1 was staffing shortages and the challenge of recruitment associated with that, obviously, and retention. So 60% of dentists surveyed said that was their number 1 challenge. So we're bringing that forward into this next year. Number 2, low reimbursement from insurance and high levels of claim denials and all of the administrative challenges associated with those things. And number 3 was rising overhead, which has really gotten out of hand here the last year or so. So why don't you go ahead and pick it up there, Brett?
So first off, the ADA's mission, it serves two roles. The first is to ensure that every member is successful. The second is to improve the overall health of the communities we're serving. And so everything we do, we're trying to find ways to serve both those topics of the mission. And so when we poll our members of what their biggest challenges are, everything that you mentioned, is a challenge to our dentists becoming successful to the level they wish to be, and it's affecting patient care. I have, personally, I practice in Colorado. And we have a hygiene shortage in Colorado. We have a dental assistant shortage in Colorado. And, last go around, I think it took us 7-8 months to hire a hygienist. Some hygienists are in Colorado, they're asking $70, $75 an hour. And if you are an insurance heavy focused practice, you get reimbursed $65 for a pro fee. And so we're seeing, the numbers don't add up with that. And so we see a big problem with that. Many of the dental personnel left the profession during the COVID time, and there was a high level of burnout, high level of anxiety about especially the role of hygiene in dentistry, and as far as living in the aerosols that they lived in with the ultrasonic cleaners they use. And so it became real, and many left the profession. Many are starting to come back, which is nice. But we've known for a long time that there was a disparity between the number of dentists that were producing out of dental school versus the number of hygienists that were producing out of hygiene school. And it came to a head, it accelerated during COVID. And so I still think we have a problem because we're not training enough hygienists. Every dentist, like a private practice dentist, has 2 hygienists, 2 working full time in some, combination of days, whatever. And I think we're training equal numbers of that. So we're working with CODA. CODA is the Commission on Dental Accreditation, because every school needs to be accredited, and CODA has some very stringent rules on what accreditation looks like and how many faculty are needed to train hygienists within the school system that they're in, a learning system that they're in, and we don't know the rhyme or reason for that. So we're advocating right now for them to allow more hygienists to be taught under the current rules. That we feel will get a boost there. Dental assistants too. A lot of people just aren't going into the market because they can make the same amount of money working for a fast food chain and get benefits that they can working at a dental office. And this comes back to an artificially governed ceiling that the dental insurance industry has over most dentists, because they have not raised the reimbursement rates to the level of to keep up with inflation and the cost of doing business today. I think that spans all three of the topics that you brought up. So we haven't been able to invest in our staff and our teams to the way that we used to, and it's starting to hit ahead that we're running into trouble. Low reimbursement rates. We are advocating for real insurance reform right now. I think the medical loss ratio bills that are going around the country are really going to help with that. For those that don't know what medical loss ratio is, the Affordable Care Act mandated that all medical insurance plans have a medical loss ratio of 85%, which means that if 85% of all the premiums collected must go towards medical care, and 15% can go towards profits, administration, and stuff like that, infrastructure. But 85% must go towards care. And that the dental insurance benefit industry has really been left unregulated for its entirety of its existence. And if we can boost or bring the dental loss ratio to the same level or close to it, we will increase utilization of the benefits. So if you have dental benefits, or if you are a practice that deals with dental insurance and dental benefits, the studies or the stats that come out of another organization, the American Association of Dental Plans, 6% of people who have dental benefits ever reach their maximum. 94% don't. And we get complaints a lot. Well, the ADA is not doing enough. They've never raised, the insurance company haven't raised their reimbursement rates. They haven't raised their cap since 1970. But bottom line is, they've got no, impotence to raise the cap because no one ever reaches the cap. And the plan design 180/50 isn't working, and many dentists. And I hate to say this, but we're not very good at promoting value to the point where patients would take money out of their pocket and pay us, especially when it gets to that 50% level for crowns and major dental care. And so, and I'm going to put a plug in for your book here, that the skills that you describe are so, to help create value for the work we do, where patients appreciate it and are willing to go through the treatment because they know it's in their best interest and it's their decision to do it, really helps. And so I just want to put that plug in there. So so we're doing, a lot to try and increase utilization. And, whatever you think about dental insurance, it does drive people to the dentist. That's one of the driving factors from the consumer standpoint. And so it is a necessary aspect of healthcare, especially in the dental world. And 95% of all practicing dentists are on some plan as a provider in some way, shape, or form.
Right. So this is kind of creating, the dental marketplace is an ecosystem, essentially. Mm-hmm. And it's being influenced by a number of things that you've just mentioned. the economy to a large degree, and 95% of the offices are significantly influenced by the behavior of a third party, because that's a primary source of their insurance stream. And to a large degree, like you said, Brett, many dentists don't know how to shift the conversation to have the relationship they have with each person to be more goal oriented, and to therefore de-emphasize the role that insurance is playing within that relationship. And this is a big step that a lot of dentists need to address if they really want to get out of this kind of dysfunctional codependency relationship that can be established with insurance companies. It's interesting in the survey that Marco referenced, he said that 42% of the dentists surveyed were planning on dropping out of some insurance networks. So it seems like we're hitting a tripwire here, and things are starting to shift. We've got a staff shortage, which is obviously influencing the hygiene side of practices, which most practices today are structured in what I would call a hygiene-driven model, meaning most of the work that ends up in the doctor's chair is really coming out of the hygiene suite on some level. And so when you start removing hygienists from that equation, and the productivity on the hygiene side of the practice starts to drop, then where is that going to get substituted for? And so I think that's one of the greater challenges that we're faced with. Can this higher volume, hygiene-centric model continue without more hygiene graduates? Because that, according to Marco, the number of graduates is in fact flat, and I think you've identified one of the most significant bottlenecks in that. Additionally, he mentioned that the number of people attending hygiene school, or not assistant training, dental assistant training, is falling. So we're looking at fewer trained clinical assistants and potentially fewer hygienists. And laid on top of that was another survey that I just saw last week, was somewhere around 35% of all practicing hygienists right now are thinking about retiring within the next 6 years. So we may very well see another leg down, because there isn't enough capacity to prop that up of new graduates. So it seems like we're hitting a tipping point, and this is going to be a big challenge for all of us. Brett,
and there's one more. There's one more aspect to the doom and gloom. I hate to bring this up, but we're a huge shortage of lab technicians as well. No one's going into that area either. And so a lot of things are being replaced with digital technology. And it's interesting to see where this is going. So what's happening, and I see, so back to, the hygiene centric, when in my practice, I, had key markers that I would track. And the hygiene production was one of them, but that wasn't my most important marker in the hygiene department. The most important marker in the hygiene department was what was diagnosed in the hygiene chair, and what's scheduled from that diagnosis. And and the hygienists that I work with are so good at educating our patients in to what the current status of their oral health is, and any issues that are prevalent, they will identify. And I'd walk into the room, and my patient would say, "Oh, hey doc, how you doing? I think I need a crown," and I didn't have to even say anything; just the picture was right up in front of them, and the picture tells 1,000 words. And and I was really good about keeping employees, because they felt a strong sense of purpose of everything they're doing was truly helping our patients improve their oral health and their overall health and their quality of life. And so it wasn't just the hygienist how much you can scrape in an hour, or the assistant how much you can suction in an hour. It was truly a partnership of each member of the team was contributing to the success of the patient in achieving their goals. We Another area that I think is an untapped market is many nurses left the nursing profession due to burnout as well. And there's some states that are looking at potentially how can we fast track and retrain nurses who have, they now have the medical knowledge. Can they get the physical knowledge in a fast track way? And talk about quality of life. There is a hygienist, they get to work normal hours, no overnights, no bedpans, no catheters coming out, and God willing, no one dying on their on their watch. And so we're looking at creative ways to bolster that, the hygiene demographic in that way. But every state has a state practice act, and every state has to be forward thinking enough to get this to happen and make those changes. And then, trying to get the dental hygiene schools to acquiesce to this potential model with a fast track is, again, bottlenecked by some of the accreditation standards currently in place.
Yeah, so these are all big challenges as we go forward here. I'm obviously biased towards a smaller practice model that has less staffing demands on it. In the hygiene-driven practice model, as you've described, the hygienists have been to a certain degree delegated the sales force of the practice, if you will. So if in your practice, Brett, you had a very health-centered mission. So everything was relational and everything was focused on what does the patient want to achieve and how do today's findings fit in with that long-term goal. Versus what I see, unfortunately, too often in the marketplace where practices are production-centered and hygienists are kind of encouraged to just find problems for the sake of increasing production for the day. And I think hygienists that get stuck in that model get burned out pretty fast because it's not as deeply fulfilling as you described. You had great retention of your staff because it was more than about money. It was more than about production. And I think this is an area that our profession can continue to work on getting better at. Thoughts on that, Brett?
Right. And, when the hygienists are commanding $75 an hour to, and so the dentist gets $65 for a pro fee from the insurance company. So they're thrusting them into the accelerated hygiene model where they're working on 2, maybe 3 patients an hour, and they're doing the scaling, and it's being followed up by a dental auxiliary to do the actual polishing. And it's treating teeth, not people. So, the stat of 46% of dentists thinking about dropping a plan is real because we've been able to make it work with us, with the volume of patients we have, with $1,000 max or a $1,500 max. We can do really well on 1 to 2 crowns a year, okay, for these patients. And now that it's not as easy to produce, people are saying this isn't working for me, and they're starting to go away from that high volume, let's take every plan kind of thing. So it's an interesting time, and then the dental students are coming out of school with a huge amount of debt, and we as the solo private practitioners, if I was going, this is what I've been saying for 15 years now, but if I were to hire a dentist right out of school and they needed $100,000 worth of salary, I'd have to have $400,000 worth of dentistry lying around for them, because they are very neophytic with their dental skills, but let alone the communication skills, they're not there, and we have to kind of feed them and grow them into the role where they can provide the value. That took me several years to figure that out, and I don't have $400,000 worth of dentistry lying around for them, so therefore I'm not hiring them. Okay, and so they're going for a place where they can be supported and grow in a higher volume group practice or dental support organization type model. And many of them are staying because they like the freedom of working 3 days a week and not have to deal with the business aspect of dentistry. And so there's a whole other conversation I think we can go in if you wish.
Right. So actually, this is a good segue into really the next variable in this complex equation that's influencing all of our futures, and that is 56% of incoming dental students are now female. So that fact brings in a very different demographic in terms of priorities and values to some degree, and it's shifting the nature of dentistry, because the average female dentist isn't necessarily interested in owning a business anymore or running a practice anymore. They want more flexible work arrangements so that they can prioritize some other really important things in their lives, such as having and raising children and so forth. So they like the flexibility of the corporate model in these bigger group practices. The flip side of it might be that they may not work as many hours in the average month because their priorities are shifted around. So we've got that going on simultaneously as the baby boomer dentists, myself included, will be retiring out. There's a significant number projected to leave dentistry within the next 3 years. So there's going to be a very big transition from the baby boomers to the millennials, essentially, with who have different expectations and different goals and so forth. You want to talk a little bit about that?
Yeah, I first have to say that my wife is a dentist. We met in dental school. We started dating our first year and we got married our fourth year. And she went on to specialize as an orthodontist. She always struggled, especially when we had young kids, about wanting to be a mom versus wanting to be an orthodontist. And I always said, well, you can only be a mom for these kids when they're this age right now, and you can always bend wires and be an orthodontist. And so, but we made it work through our own private practice. But I think it's universal. Female and male have different ways they want to work. Where they want fewer hours, they want more benefits, they want more flexibility, they want to travel, they want license portability, that they will might want to practice in different parts of the country or different parts of the world even. But males can't have babies. I don't want to sound like we're just focusing on females, but it is but I know many young male doctors who are dentists who are taking paternity leave as well, which is great. And but it does shift the workforce, because if the number of dentists that the market needs to be full time, and not everyone in the current market, especially the new ones, are not working full time at the same level the baby boomers are, there's going to be a shortage. And this could be one of the reasons why so many new dental schools are popping up, and why dental schools, increase the size of their dental school classes. So, some feel there's a plethora, too many dentists in the market, and some feel there's not enough. And depending on where you are, like I practice in Denver. We have a saturation of the market of dentists. It's very hard to find a job. I've spoke with 2 young dentists who just graduated, who are having trouble finding jobs in the major cities where they are, because they're saturated. But they don't want to go to the rural areas where there's not as much opportunities in the goals that they want to accomplish in their life, in the rural areas as there are in the big cities. But they're still choosing the cities. Eventually, I think the laws of economics will spread out the workforce to areas, because people need to make money and produce as a dentist, and you can't produce if you don't have a job, and you're going to go where the jobs are eventually. So so there's two peaks in the demographics of dentists that are currently in the marketplace. And, the baby boomers are ready to pop off, as you said. They're going to age out. And but then the Gen X, which is my generation, We have a lull of dentists. And if you remember back in the 80s and 90s, I think my freshman year of dental school, 1991, we had 60 dentists, 60 dental students in my class, but the senior class in my school had 120 dentists in their class. And so we were part of that initial part of that shrinkage. And so over time, the sheer volume of dentists decreased for my generation. And that's why we're feeling this right now. The Gen X is always the forgotten generation in this, but right now we're going to be shouldering a lot of the workforce because we still like to work full time, and we have the dental skills to treat a lot of patients and make a big difference in their lives.
So let's add one more complication, as if this isn't complicated enough. In the middle of all of this, we also have patients that are aging out in terms of, to a large degree, the fat part of the bell curve of my practice life has been serving older patients with complicated restorative needs. When strangers come up to me and ask me what I do, and they say, I say I'm a dentist. Well, they ask what kind of dentist I am. I say, well, I tend to work with people to resolve complicated problems. And that's essentially what I've done for a long, long time. So we have this shift of these elderly people whose dental needs were not taken care of in the 1930s and the 1940s. A lot of them didn't go to the dentist until they were 15 or sometimes 20 years old. So they come into our life already missing a lot of teeth. These are great opportunities for rehabilitative and restorative dentistry. And we've enjoyed many decades now of those types of patients, but those are going away, and the needs of the younger generation are different now, as well as the attention of dentistry as we now turn our attention towards the importance of breathing well and sleeping at night, and the critical nature of growth and development, and how early on in a child's life intervention is indicated, sometimes as young as 2 or 3 years old, in making sure that there's proper mid-face development and an airway development and all that. So we're seeing, I think, as I kind of look into the somewhat cloudy crystal ball, the type of dentistry is going to change. The type of dentistry people are doing is going to change, and the focus of attention, I think, is going to shift more towards pediatrics and growth and development and orthodontics instead of this heavy restorative lifestyle that I've lived under.
Yeah. So first off, with the changing of demographics of our patients, that's very real. The baby boomer generation, my parents' generation, had a ton of dentistry to redo in their mouth, and it was very complicated. And so my generation has much less dentistry in our mouths than my parents' generation, and then the generation below has even less dentistry than my generation. And so it's going to be different. And in our current model, we get paid by what we produce, and if there's not a lot of dentistry to produce, the payment situation is going to be different. And so dentistry it really is going to be shifting to a more proactive, comprehensive health conversations, and we at the ADA are really looking at, and I hate to be facetious, but we call teeth luxury bones. Okay, if you've got money, you can get them fixed. If you don't, you can't. Okay, but yet if I needed a hip replacement, I can get that fixed, whether I have money or not. So the public benefit expansion is leading us towards whole health, how dentistry can improve overall health. And so you brought in growth and development, you brought in breathing conversation. There's so many dentists that are treating breathing disorders, when I did my training with Pete Dawson, it was like, just equilibrate the mouth, get them in CR, get the joint healthy, and everything gets better in their lives. But we found that, 20-25% of our patients didn't get better. They're still clenching and grinding. And we looked deeper, and we saw there were breathing issues that was leading to the clenching and grinding and the parafunctional habits. And so we started looking at how do we treat that? How can we help? How can dentistry help with people's airways? And it just started to explode because we found ways to get remunerated for it. Okay. And if we can find ways to get remunerated to help our patients with their diabetic A1C control, that will also explode in the market, and no matter what practice model you're in. And so, yeah, I agree. There's the Western lifestyle has changed the way we grow and develop, but I feel that everyone deserves to have a healthy, functioning, aesthetically pleasing mouth. And however that happens, whether it's through the private practice, relationship-based practice, the private practice, PPO heavy practice, or whether it's in the public realm, Medicaid, Medicare, I feel that everyone should have that to improve their overall health, because it is connected. It should not be considered a luxury bone.
Right. So we've essentially reached the point where the conversation is over with regard to whether or not oral health and systemic health are related. The data is in and so heavy that really what you're discussing here, Brad, is the need for medicine and dentistry to merge more effectively and stop functioning as silos that don't communicate and work and collaborate very effectively. I mean, if I could, imagine a better future for all of us and the people that follow behind us, it's that. It's an elevation of dentistry up to being much more of a peer of our medical profession and working side by side with them, and with regard to growth and development issues, with regard to dietary issues, with regard to systemic issues that are being negatively influenced by by oral health. So that to me is an exciting thing. That's a very significant change that can happen right at the time that these other demographic shifts that we touched on is occurring.
Yeah, and it's exciting when you have people like you, like Whit Wilkerson with his book, The Shift, ascribing to how dentistry can help someone with their overall health. Top dentists in the world are saying, hey, we need to look bigger. Okay, just what Pete Dawson taught us. We have to be, physicians of the masticatory system. So it's happening in this, this high-end relationship-based fee-for-service model. It's also happening in the FQHC models, okay, where public health offices, especially on the medical side, their medicine and dentistry are under the same roof. And a diabetic patient, let's say a Hispanic male of 55, is diagnosed with diabetes on the medical side of one of these FQHCs, they're automatically shifted over to the dental to get, an evaluation and periodontal care to help, balance out and stabilize the A1C. It's also happening in several DSO models, particularly Pacific Dental. They are starting to have offices with medicine and dentistry under the same roof. And they are doing medical testing on the dental side for A1C, blood pressure. I mean, everyone should take blood pressures, but they're starting to look at the congruent paths, how we can both support each other. The problem is the payment models are still separate. I'm in San Diego right now at an ASDA district conference. There's 400 dental students, and they're all being taught about the correlations with dentistry and medicine, and just like we were taught when we were in dental school. But then when we get out of dental school, it becomes detached. And it's even hard for us to get physicians to call us back or develop relationships. And I found in my practice, I found a group of plastic surgeons. I found a group of concierge medicine model doctors who would refer me patients, and I would refer them patients, because my patients were already ready to, be as healthy as they can be, and were willing to pay for it. But not everybody comes that way. And so we have to find ways to build those bridges. I remember a couple of years ago, a dental hygienist and I worked that worked with me, and I spoke at a cardiology summit in Denver, and we talked about the article that Wood Wilkerson talks about, where 79% of patients who are undergoing cardiac catheterization, they went and grew out, tested what bacteria are in those plaques when they did the cardiac cath around the cardiac arteries, and 79% of them had strep viridans in them. Okay, strep viridans only lives in the mouth. The only way it could get there is through bloodstream and inflammatory process of the mouth. I'm not saying that strep viridans caused the plaque, but it definitely contributed to the inflammation. And I asked the docs if they knew of that study, and they all kind of, yeah, we know it. I mean, is Circulation a real cardiology journal, or is it like Circulatory Today, like we have, and
Right.
it's peer reviewed, it's one of the best. And I'm like, well, this, what do you do for your patients? If 80% of them, 79% of them have these plaques and it's strep viridin in there, well, we look and see if there's any, infection, and and then I showed them pictures. I go, does this look like a healthy smile? Like, oh yeah, this is great. Then I show them a retracted view, and I show an abscess, and what do you do about that? And the bottom line came down to, because we're on different payment models, they don't send to the dentist on a regular basis, but yet we know it'll help their health.
This would be a good time to introduce myself. I've been sitting quietly and unknown. For people who are watching Practice Perspectives, I've been working with Paul Henny in this endeavor now for probably 20 or more years, creating videos and being aware of what's going on. But as a person with a mouth, I am the person you folks treat. I am not a dentist. I think we all realize that the medical model in this country, whether it be the dental model or the heart surgeons or the general practitioners, that people are in silos. They're just going down their silos, trying to make money, trying to make the insurance plan work. How do you encourage us, those of us who are consumers, so that we're all aware of, I read this thing and I was very much aware of practically everything that was in this. What's wrong with our practice models? What can we do to encourage the patients, the people who are using you, to start seeing more holistic practices and more people concerned about what's causing all this? If it's bacteria, why don't we do something about it? Can either of you speak to that, to help someone who's watching this? I'm not the only one thinking of this. Someone's watching this saying, well, so what? What are we going to do?
I could take a stab at it first, if that's okay, Paul.
Go ahead, Brett.
I see a shift happening in the culture of our country towards self-directed health, life hacks, health hacks. It's a small percentage, but the different medias that are present now that weren't present in the past, such as this, podcasts or videos describing, health, that you didn't have to go through the major media operations to get the word out. People are growing this way because they want to live better lives. They're taking health measures to improve their health in their own hands. The current status of healthcare in this country isn't healthcare, it's disease care. It's
right.
Sick care. Okay. And the problem is, especially in dentistry, we don't get paid to talk prevention. Okay. Medicine too. Medicine is just overwhelmed. They can't keep up with the health problems. They want to talk prevention, but there's, so auxiliaries are starting to come in to do that. And, so in medicine, value-based care is starting to become a thing. And there's a big scare. Is it going to come into dentistry? I don't think it's coming into dentistry anytime soon. We're seeing it in some of the Medicaid markets, but not in the major market. But the value-based care, where physicians get paid based on health outcomes, and they've got some definitions of what that looks like in the medical side. In the dental side, there's really no value quality assurance measures, not enough of them to really show that this is a success, and therefore you should be paid accordingly, or that this is a failure, you should be paid accordingly. So until quality measures are made in the system, then I think value-based care will be put on hold. But I think there's a cultural shift of us, especially my generation, that are looking to improve our health, and we're finding ways to do that. So I'll throw it over to Paul.
Yeah, I mean, I think there's been a solid, steady trend really for the past 30 or more years in a small segment of the market towards health-centeredness. I mean, just go to your average strip mall and see the GNC store there, and fitness places and all kinds of things that are very much centered around this. What I'm seeing is COVID and kind of the failure of the medical system really to appropriately manage that crisis, in combination with people's access to things like podcasts and alternative media, has really put that on steroids. People that were health-centered realized that they couldn't wait around for medicine to come in and rescue them. They started searching for ways to take more control of their situation and manage it successfully as much as they can outside of the medical network, because it just became obvious the medical system became overwhelmed during that crisis. And so that's what I've seen. And a lot of my patients have become much more aware of all of these things, and having much deeper conversations with them about whole health, sleep, all of these things. I'm just seeing that as a meta trend that really accelerated over the last couple of years. So if you posture yourself as a practitioner to be ready for those conversations and to serve those people well, the conversation to merge dental health into that is so easy. We have become it's become so normalized in dentistry for us to be working in bloody mouths that we don't think about the fact that that's bacteremia like crazy. Every person that has gingivitis in our practice has bacteremia on a regular basis. And just like Brett said, these oral bacteria are ending up all over the body, in the brains, in joints, and coronary artery plaque and everything. And that's the studies are here. That's not speculation anymore. So people that are aware, those kinds of conversations have gotten very, very easy for me. So they're primed. They're ready for the dentists who have staged up and are ready to meet that situation, Stan.
Mm-hmm.
Good.
And from an economic standpoint, though, there's still the culture of who should pay for our care. And, is dentistry a privilege or is it a right? Is healthcare a privilege or a right? You talked about COVID. I think a lot of people were enlightened because the much higher risk of severe consequences of getting COVID, if you had comorbidities of like hypertension or diabetes, you were way worse off. Yeah. And so there was an impetus. I saw a big spike of my patients wanting to get healthier. They were all talking about their new exercise routine and all the stuff they were doing at home, on the videos, and but again, is healthcare a privilege or is it a right? People culturally still feel that dentistry, healthcare should be paid by an outside entity.
Well, and I'll just add to that comment that I think we're all in agreement here that we can't give health to anyone other than ourselves. So optimal health really is a personal pursuit. And I kind of touched on that in the book. No matter how big medical or dental insurance gets, it will not create health in anyone, really. It's what that person does day in and day out, what they put in their body. And what they do with their body every day really is the big driver. So sometimes we get fooled into thinking that really all we need to do is pump more money into this. It's really, I think at the bottom of it is we need to have more effective relationships with our patients. Obviously more financial support facilitates that moving forward faster and more effectively. But if we aren't having the conversations, if we aren't ready to have the conversations, if our practice isn't oriented towards priming those conversations, then then it doesn't happen. It just doesn't happen.
Right.
And dentistry just becomes very reductionistic and too-centered, as you said at the very beginning of this conversation.
And people still come to the dentist for preventive health measures. They're coming to get their 6-month cleaning or their 3-month cleaning as a preventive measure. And so the opportunity is ripe to have those conversations. And, I think part of the reason that the hygienists that I work with that were most happy, because they were really doing, not only helping improve the health of the periodontal structures, but they were having these conversations with the patients that weren't getting better. We removed the bacteria plaque, and you're doing a great job with your home care, but you still have inflammation. Something else is going on, and they send them to their doctor, and they come back as a newly diagnosed diabetic, and and we saved their lives as a result of that, because we had the built in our systems to have these conversations with our patients. And we had recalls, so after we did scaling and root planing, we bring them back 6 weeks later to see how they're doing, and see what the health status is of the gums. And when something wasn't right, we had time built in to do that. We didn't get paid for that, but we got paid in different ways.
Right.
Okay. And,
right.
and I think many dentists get stuck. Well, I'm not getting paid for that, I'm not going to do it. So,
and then that in turn set, and that can be kind of a doom loop, because
right.
you're doing operative and restorative procedures on people that aren't healthy, and you get stuck in that place. It's really easy to end up there, and I think that's where a lot of frustrations with dentists originate from, is working with people that they know in their heart that their patients aren't moving towards health. They're just kind of keeping their finger in the dike, and they're trying to maintain a slowly declining status quo. And
right.
I think that's the challenge for us as dentists, where we really are in the driver's seat to lead people towards a higher level of health, even systemic health. But we've got to create opportunities for relationships that make that happen.
Right.
Stan?
Thank you for that answer. I think, again, I would like to see a continuation of these conversations, because both of you have such a rich background in understanding more of the healthcare model of dentistry. Those of us who have just been going to a lot of dentists all of our lives, we mostly have been confronted with people who just fix the problem and let you walk out the door, and they're not really looking at the nature of your gums. And unfortunately, most of the people that I know are aware of that and concerned about it. But this has been going on now for 49 minutes, which I think is probably as long as anyone will watch a video. And so I think it might be well to kind of wrap up with some encouraging thoughts from both of you about, I'm looking at this practice, what are the main challenges you see? The chief economy guy at the American Dental Association. I'd like a few thoughts on what are the good things about to happen, so we can wrap this up. Why don't you hit a few things of that as we get to the end, Brett, because you're in a position to know some of the good things about to happen.
So the beautiful thing about challenges is that the human spirit finds ways to innovate. And we've got some amazing innovations coming down the pike. CAD/CAM is becoming, much more prevalent. Same day crowns, 3D printed restorations are becoming more widespread. I just attended a lecture on virtual reality and treatment planning in 3 dimensions to make things move quicker. And with quicker, I know that some of these things are very expensive, but over time, as they become more and more integrated, just like digital x-rays, it becomes more available to the masses, that we're going to be able to deliver dentistry in higher quality and more efficient manner, for the masses. And I'm very, very excited about that. We didn't even touch on that yet, but so I'm looking.
I think it would be fun to have a conversation about some of the exciting things we all can expect out here in the world of human beings that you're providing for us.
Yes.
And Paul, I know you're excited about this because there's some things on the horizon that you're aware of that I'm aware of through you. And I think there's an exciting future for people understanding that the mouth is a gateway to a lot of issues that we're having.
Yeah, I mean, I think that the biggest danger is to think that tomorrow is going to look like yesterday. The trends and the technology that you just mentioned, Brad, AI, these things are going to change the way we practice and the way we think about dentistry. And when you combine that with what we know about all the growth and development issues and how we can intervene now in growth and development in children early on, develop a more proper, healthy adult early on, really to avoid a lot of extensive orthodontics and to rethink orthodontics. Because we're engaged with people in an earlier relationship that's more focused on health and more effective relationships and all that. And then if we roll into this conversation, things like Emily Stein, PhD's prebiotic, which may end up reducing dental caries and periodontitis to levels that we couldn't have even imagined. So that's another shift in the workforce and how that workforce would be deployed and what their roles would be. So I think that would be my comment, that the biggest danger is to assume that tomorrow will look a lot like yesterday.
Yeah.
Yeah.
Yeah. And I have one more, if I can just throw in, this past year, CMS asked the ADA to comment, and many other dental and medical organizations, if they were going to expand the definition of medical necessity for dental care, what would it look like? And we ended up expanding that definition. So now people who have oral cancer can get dental care covered by Medicare. Things like that are these conversations are starting to happen where the powers that be are seeing the value of how dentistry can help improve outcomes in medicine. So, in 10, 15 years from now, it's going to be a much different payment model. And it's going to be a much different practice model. And it's really exciting.
Oh, that's great. Well, Paul, why don't you close this out and tell us a little bit about, you've got Emily Stein coming in, I believe, to the Bob Barkley Study Club.
Yeah, well, first, thanks, Brett. Another awesome conversation.
Yes.
If you didn't catch the first interview with Brett, I encourage you to track that down on the Bob Barkley Study Club and other places and listen to that. It's fantastic, inspiring story. And then on into the future, the Bob Barkley Study Club is going to have a meeting with Emily Stein, PhD, who developed a prebiotic that's going to be available in a number of forms. But the prebiotic, in the shortest explanation, starves out all the pathogens of the mouth. And I'm talking about gingivitis, periodontitis, and dental caries. So can you imagine having a practice where there's virtually none of those things and you could focus your attention on other things? And in addition to that, it reduces the amount of calculus that builds up in patients' mouths. So maybe you don't need as many hygienists. So this particular idea, this patented idea, it to me is a game changer. Emily's coming in here to Bob Barkley Study Club in Virginia to speak for a full day on the microbiology of that. So that'll be the microbiome of the mouth, microbiome of the gut, microbiome of the brain, which is, we're not so used to thinking about there being a microbiome of the brain, but bacteria end up in all of these places. And a lot of it starts in the mouth and the health of the mouth. So Emily's going to talk extensively about that. And then on day 2, Mike Schuster, the legendary Mike Schuster, is coming in for a day to talk about his long, amazing journey through dentistry and his relationship with Dr. Pankey and Bob Barkley and Harold Worth and Chuck Sorensen and all of these people, and how that shaped his future and led up to him creating the Schuster Center for Professional Development in Arizona. So that's going to be really fun. It's just sitting and listening to these stories of these amazing people that really shaped dentistry into what a large part of what we know it to be today. So if you're interested in that, just at the bottom of the screen there, get in touch with me and I can get you some more information about that. And till next time, thank you, Stan. Thank you, Brett. We'll catch up with you again on another Practice Perspectives.